don't look now, but 2026 kind of just around the corner, which is outrageous to say out loud, but we're always taking our time and having good conversations here on the Just Start the Conversation podcast. It's brought to you by St. Luke's Penn Foundation, joined as always by Amie, Alanson, Dundon. Amie, how are we? It's been too long. I hope things are well.
It does feel like it's been a while. Things are well. Things are a little bit of a crisp feel in the air and mid-football. And again, we might be listening to this later, but I'll tell you what, things are going good.
You had me at crisp and football. You had me right there. We have an excellent guest with us today, Dr. Christopher McCarthy, who is with St. Luke's Penn Foundation. He is a psychiatrist, to talk to us about Unpacking Psychosis, a conversation on schizophrenia and stigma. Dr. McCarthy, first and foremost, how are you today? Thank you so much for joining us. Great to have you on the Just Start the Conversation podcast.
I'm doing great. Thank you for having me. I'll say that I recently started working for St. Luke's as a full-time attending in July 2025, and it's been a wonderful ride. I've been to the older adult units, the younger adult units, the child and adolescent units. I've done outpatient, partial hospitalization programs. I've really seen the gambit of what St. Luke's has to offer, and routinely I do electroconvulsive therapy, generally once every other week for St. Luke's as well. So I feel like at St. Luke's I've had an enormous amount of opportunities, not only to see all spectrum of psychiatric disorders, but also neuromodulation techniques that St. Luke's is a part of.
Amie, I can kind of see you smiling and nodding like you like this guy. He hasn't been here long, but I can see by your face, you're like, I like what this guy's doing, and that's excellent. So, Dr. McCarthy, I'm actually going to start with you here because I wonder how many people really understand what schizophrenia is. So I'm going to ask you to go into that a little bit, and then what kind of drew you to the role that you're in now? What made you want to go down the path of psychiatry?
Of course. So what I was going to say is, when it comes to schizophrenia, I think that it's important to talk about what psychosis is first. So when we talk about psychosis, the textbook definition of psychosis is a disconnection from reality. And the way I would take that, and we'll talk about that, what I would say is basically, if you imagine a radio, your radio is receiving the signal, but you haven't tuned the radio into the station, so you're getting all these static sounds. So basically, with psychosis, the real world is still happening around an individual, but they're not able to interpret and interact with that environment. So a disconnection from reality. When we talk about psychosis, there are, in the Diagnostic and Statistic Manual, which is the diagnostic handbook that the American psychiatrists use to distinguish psychotic disorders, there is brief psychotic disorder, schizophreniform disorder, and schizophrenia. So the criteria for a diagnosis of brief psychotic disorder, you have to have either delusions, hallucinations, or disorganization of speech, and grossly disorganized behavior. You have to meet at least one of the first three criteria at a bare minimum. Now, for a brief psychotic disorder, that is expected to last less than a month, with an expected return to baseline thereafter. Now, if those symptoms persist, and you have two of those criteria, again, delusions, which are fixed false beliefs, hallucinations, disorganized speech, or disorganized and catatonic behavior, if you meet at least two of those criteria for a period of less than 6 months, but more than a month, you meet the diagnosis of schizophreniform disorder. Now, for schizophrenia, you have these symptoms that persist for longer than 6 months, but you also have a documented decline in social functioning, which would be in your home environment, at your work, and that's one of the diagnostic criteria that distinguishes schizophrenia from schizophreniform disorder. So to sum it all up, an individual that has been diagnosed with schizophrenia has had 6 months of these delusions, hallucinations, or disorganized behavior, and it has resulted in an impairment in their day-to-day life functioning, both socially and occupationally.
Amie, I want to talk about that as I can kind of see you're shaking your head because that's a lot. That feels like a lot to digest, not only maybe for someone individually, but for somebody significant in their life that might see some of these signs and think, what are we not maybe understanding here? Can you go into that there for the individual, Amie, for a family, for a loved one, for someone that might be seeing some of these signs and saying, I think we've got to talk to a professional about maybe what's going on here.
Yeah, Dr. McCarthy certainly summed that up beautifully, as I knew he would. I think the important thing, all of that's important, but I think to kind of break it down a little bit further for families, I think what you're going to see if you're living with someone or know someone with schizophrenia is really what I would classify as really a profound break from reality. And that can be really difficult to discern sometimes, because sometimes we have families weeding out substance use issues. Mm-hmm. Lots of things can look like this. Lots of symptoms can mimic this. Schizophrenia age of onset is usually late teens, correct? Early 20s?
Correct.
So keep that in mind too when we're looking at our loved ones and their age range. Our doctors will look at that and say, well, this just started when this person was 61. Maybe it's not likely that it's schizophrenia. Maybe we need to do a differential diagnosis. So age of onset really is important with us. But I think for families, it's really helping people, it's really advocating for your loved ones is a lot of what the family role is, helping with cooking, cleaning, providing a very accepting environment. This is a really difficult disorder to live with. If you can think about the way Dr. McCarthy described it as constantly walking around with static in your head in between radio stations, right? And so you're hearing that, but also you may at the same time be having visual hallucinations. So you're seeing things that aren't there as well. So they're not there, usually, because hopefully you've gotten some treatment and you can start to discern reality from hallucination. But imagine walking around all day and seeing figures or forms that you kind of logically know aren't there, but you see them. They're real. Your brain is putting them there. So now you're kind of living in this static world, or maybe a world where I sometimes describe it as, think of it that you're at a cocktail party, or even that you're at a big sporting event, and all of the voices around you are talking at once, and they're all talking at you at once at the same time all day. And you still have to navigate, to Dr. McCarthy's point, the world around you, because everybody else is living a normal, seeing the reality as it really is, and you have to navigate in that world. And it can be really off-putting for society to be around people with a schizophreniform disorder and navigate that, because it can look scary if you don't know what it is, and somebody's maybe responding to external or internal stimuli, and you don't see what they're seeing, you don't hear what they're hearing, so it seems very odd. So it's very much important for loved ones and friends to get a lot of education and help folks get treated, because the earlier we treat psychosis, the better the outcome is.
Yeah, Dr. McCarthy, I'm going to come right back to you on this, because we've already used the phrase a lot to unpack. And that's part of the reason why I kind of asked outright for the definition of schizophrenia and unpacking psychosis. What's something you wish people understood more? Because it does feel like there's a lot of depth to this. And especially, to Amie's point, you want to be supportive. You want to be there for whoever it might be in your life that might be dealing with this. Right. Just kind of off the jump, one of the first things that maybe you wish people understood a little bit more about schizophrenia.
Well, I would start off, and I thought about this a little bit. The first thing I would say is I wish people knew more about the impact of drugs. So when it comes to schizophrenia, like we were saying, it's that period of 6 months of the delusions, hallucinations, disorganized speech, disorganized and bizarre behavior. Now, schizophrenia does not develop overnight. We know that, just like Amie was saying, that the average age of onset is in the late teens, early 20s. Now, what a lot of psychiatric textbooks talks about are the topics of what we call the schizophrenial prodrome. So there are believed to be multiple contributing factors to the development of a full-on psychotic episode. And leading to the diagnosis of schizophrenia. So to start things very beginning, we don't know exactly why, but if individuals are born in the winter months or they're born in very early spring, they're more likely to have schizophrenia. There's a genetic component. It's believed to be between 60 to 80% a genetic component that results in the development of schizophrenia. If your parents have it, the studies say you're about 10% likely to have it. If your twin has it, identical twin, you're about 50% also likely to have schizophrenia. So these genetic factors are a major thing. Hypoxia at birth, being born in the winter months contributes. We also see that urban environments, growing up in an urban environment, increases your risk of schizophrenia. Frequent moving around, migration from one country to another country, these are all contributing factors. Now, with the topic of drugs, I wish people knew that psychoactive substances increase your risk for schizophrenia and really other psychotic disorders as well. So mind-altering substances may alter the mind in the moment of use, but they may alter the mind long thereafter. And the drug use, in particular methamphetamine and marijuana, I've seen many cases that have resulted in long-term, long-standing psychosis. So you have all these factors that contribute to schizophrenia, and then you have what we refer to as the schizophrenial prodrome. This is generally referred to as a year before the full onset of psychosis symptoms, where people aren't quite acting like themselves. They're withdrawn, they're doing some unusual behaviors, they're not speaking to family, they're isolated in their room, and ultimately, I would say the time to act is when these bizarre behaviors start to come out, when the family sees this notable deviation in behavior, because there is a possibility of preventing a full onset episode of psychosis if they get the appropriate treatment before that first psychotic break.
Amie, can we talk a little bit about that family dynamic? Because I've got to think, you both are professionals in this field. I think about being a teenager and, kind of seeing something that I don't want to use negative words here, but your assessment might be, especially as a teenager and you don't know the world yet, you don't know what's going on. Something here might be going crazy. Something here might be a little different than what you're used to as the quote unquote norm. I want to go into a little bit of that dynamic for people that might be kind of naive to what schizophrenia might be, because I feel like it could be, especially, again, I'll come back to a teenager, like seeing somebody in an episode might be a little bit scary, might be hard to understand, and you don't know exactly what's going on. I just kind of want to go into how you kind of would explain that for somebody in your position that maybe is working with a family, working with an individual on just what exactly is kind of going on during an episode.
This is where family therapy is so important, right? This is where we want the person who's affected by the symptoms to be sitting down with a therapist and their family together so that everybody can start to understand what's happening in that person's mind, right, in their world. It's so important for us to talk openly about what we're seeing. So if I'm a parent and I'm seeing some bizarre behavior in my teenager, I need to not ignore that. I need to address it. I need to ask about it. I need to say, help me understand. You don't seem like yourself right now. Here are some examples of things that you've said. Dr. McCarthy talked a little bit about disorganized speech. I call that word salad. It's kind of how I describe it to families, right? So you might, your loved one may be speaking and it's coming out as just this word salad, and it makes no sense to you. In our world, that's called disorganized speech, right? And that comes from everything we talked about earlier, all the symptoms that person's experiencing. So we want to be really open and ask the questions and not be afraid to ask them. What you said just didn't make sense right now. Do you know what you just said? Here's what I heard you say. Tell me what's going on with you right now. What are you hearing in your head? What are you seeing? And ultimately, if you're worried, if you have an inkling that this is going on, you need to get your loved one to their primary care physician as a start to say, because we want to rule out, to Dr. McCarthy's point, drug use, We want to rule out something else biologically that might be happening to that person. And we want to rule out other psychiatric disorders. So don't try to deal with this yourself without professional intervention as a family, because we want to help you get it right. And to Dr. McCarthy's point, the earlier we can diagnose this and start treating it we have very good psychiatric medications for schizophrenia in 2025. So the earlier we can get this properly diagnosed and treat it as a family disease, right? Because anybody living with someone who's living with a psychotic disorder, schizophrenia, schizophreniform disorder, this is a family disorder. That person's going to need a lot of support. They're going to need a lot of help. And they're going to need a lot of therapy. And as a family, it's really important to get that therapy. And we do have some good therapy and some good programs that we know really do help folks with their ability to live independently or to live in housing with some other people. This isn't a diagnosis that families should feel is necessarily dooming, right? There's a lot of programs, therapies, medications out there to help. So I think the most important message to family is there's help, there's good therapy, there's good programs, there's great psychiatrists like Dr. McCarthy, who you can go and kind of work this through as a family and really, really, really follow physician orders with a psychotic disorder treatment regimen.
Dr. McCarthy, I kind of want to come back to this idea of the stigma for your patients. As Amie alludes to having an open dialogue, don't be dismissive. There probably is for a lot of people a stigma that's around schizophrenia and psychosis in general. Can you go into a little bit about the effect that it has on your patients? I've got to think from a social element that can be really difficult, especially upon understanding that that's your diagnosis, that could be probably a little difficult to try to wrap your arms around that and then go out and try to, interact socially with folks. Just kind of the stigma and the effect that it has on patients.
I see. Well, I think the first thing that we have to talk about is the stigma of medications. The studies show that these medications that we prescribe, the antipsychotic medications, really in the long term, 50% of people will take them. And that's an issue because just like Amie said, really the more episodes of psychosis you have, the more breaks from reality, the harder it is to go back. We can understand that from a neurologic standpoint, but we can also just understand that from a practical standpoint. Young individuals are going to college, they're getting a job, they're learning how to drive. The more we pull you away from reality and doing the things that lay the foundation for your life, the harder it is to just step back into the middle of the story. So I think the first thing is that there's a lot of stigma about the medications, the belief that, well, I'm feeling good now and I don't need these medications anymore. And I think that's a tough pill to swallow. I would say that we have amazing and wonderful treatments for schizophrenia, but make no mistake, it is a chronic condition and it requires continued follow-up and treatment. And that's why talking with your doctor about options, not only pills, but long-acting injectable options, which St. Luke's provides and we have infusion centers, I think that that's the best way to achieve success. Not only is there some stigma about pills, there's also a stigma about the long-acting injectable medications. I would say that the stigma exists not only for the patients, but for doctors. There are many doctors that, let's say, they would shy away from an injection because of the fact that that's something that maybe they're not as comfortable with, or they're worried about the impact it'll have on the patient's life, having to go to this center, and then just generally knowing that many people don't like needles. The studies show that for first episodes of psychosis, first break psychosis, the best chance we have for continued success is actually pursuing a long-acting injectable because of the adherence and how that'll help ensure they get to appropriate follow-up. So the studies are there. Now, as to the stigma, I think there's a lot of stigma that they won't be able to return to their lives. And I would say I don't think that's the case. I think they can return to their lives. I think that there's always going to be a new normal with any sort of chronic medical condition, whether it's heart disease, lung disease, or schizophrenia. But I think that it's important to understand that you can hold a job, that you can manage your finances, you can live independently, you can do really anything you put your mind to. It's just the fact that it's really important to understand the condition, the nature of the condition, the importance of seeing your psychiatrist and therapist and finding medicines that work for you or don't work for you. And also just being mindful that all medicines have risks and benefits, and leading an active lifestyle to address some of those negative benefits of the antipsychotic medications.
I have to imagine for people in your positions, trust has to be a vital part of trying to help a patient that's battling psychosis or schizophrenia. Amie, I'm going to start with you. Building that trust for someone who, may be experiencing delusions or paranoia. How do you approach it? I mean, it's got to be, to be kind of blunt with the question, like it's got to be, obviously you have to be sensitive in kind of how you approach it. For you two in your positions, kind of how do you approach someone who has that diagnosis?
I think a lot of it is education, right? It's trust is built with consistency. So being able to have regular therapy sessions that aren't interrupted or canceled or scheduled too far apart, being able to get a hold of your doctor if you have a question about medications, or his or her office and their nursing staff to ask questions. It's being there and being consistent and treating over time, because unfortunately this is a chronic disease. So this is a lifelong treatment team that ideally somebody would have. And that trust gets built over time. And as you can imagine, if somebody has a lot of paranoia, it can get tricky sometimes with folks because, folks that don't have consistently treated psychosis, really often we see more symptoms. They have more stays in the hospital. They have just poorer thinking and poorer processing skills, and then poorer social outcomes. So the more consistent their treatment team can be, the more effective we can keep trust. It's very difficult, Crockett. You're right. It's difficult. And I would say this is where, to go back to your stigma question, this is where some of the stigma comes in, because society will see, somebody, he or she is back in the hospital again. He or she is back in the hospital again, and not really understand, it was because maybe a long-acting injectable was missed, or maybe it's because medication adherence, they were not in a place where they were thinking clearly enough to take their meds, and there was no one to help them, right? So I think it's so important to be able to really find some empathy for folks. If I was walking around all day with the noise and the voices in my head and the paranoia and the visual hallucinations and trying to live my life and put things together, and I wasn't able to kind of do my meds the way I needed to, it would be very hard for me to trust anybody. So
Sure.
You can imagine this is why we have teams that are specially designed, therapeutic teams with psychiatrists on them to help people in their communities. We call them assertive community treatment teams, right? ACT teams, where we will have a nurse, we will have a peer support person, we will have a psychiatrist, we will have a therapist, we will have a housing expert. And that team wraps around folks, many of them with a schizophreniform disorder or a schizophrenia or psychosis, to help them to be able to live and stay and thrive in their community and not have to be hospitalized long term. So it's just very important that the right team is built around you, and that's how you build trust in your team.
Dr. McCarthy, I want to come to you and kind of talk about the recovery aspect of things and the stability that could be there for someone that's living with schizophrenia. I think maybe one of the things that's a little bit misunderstood, and I'll speak for myself, naive to the topic. That's part of what I do as the host of this podcast, is maybe ask the questions of what I think someone who would be listening would ask. I think about something like a panic attack, and how a panic attack can kind of set in for somebody who, has had a history with panic attacks, that all of a sudden maybe perhaps a traumatic event might lead to a panic attack. As we talk about recovery and stability and living with schizophrenia, could trauma produce any sort of reaction for an individual? And if not necessarily that, if there's not really a particular thing that you can look at that says maybe triggers an episode, what might be something that, as a caregiver, as somebody who knows that I've got somebody close to me in my life that has this diagnosis, might be able to look at as we're going down the road of recovery and stability, that might say, hey, perhaps an episode or perhaps something is going on that's coming up that we all can be aware of, that we know that, okay, maybe this is the next step to go and visit our doctor, our ACT team, whoever that might be.
Mm-hmm. So with regards to recovery and trauma, so you're asking if trauma can impact psychosis. The answer is absolutely. So we know this from a logical conclusion. At academic centers, they use a scale. It's called the PANS, the Positive and Negative Symptom Scale. The reason that I bring this up is we know just by giving placebo, just a pill that does nothing, we know that the positive and negative symptom scale can decrease. So there is an absolute anxiety component. There is a component to your environment and what you believe that the medicines will and won't do. If we take that and we extrapolate that, we would say that not only is the consistency of the environment a factor in the worsening and bettering of psychosis, but we know that trauma absolutely can worsen psychosis. So even if you're on the same dose of medicine, depending on the things that occur in your day-to-day life, your psychosis can get better and worse. It's unfortunately, psychosis is not a static topic, and for individuals that have chronic struggles with psychosis, we can see an ebbing and flowing as their life stressors get better and worse. So I would say absolutely trauma has an impact. Now, with regards to a recovery mindset, so at St. Luke's we have a unit, it's called the Extended Acute Care Unit, and individuals from multiple hospital systems, not just St. Luke's, end up going there after they've been initially stabilized on an acute unit. The purpose of the Extended Care Unit, like a drug and alcohol rehab, is really with the regards to insight-oriented recovery. And just like we're talking about, having people accept such a diagnosis of a chronic condition like schizophrenia is challenging. And I would say that the topic of recovery, just like the 12-step program for AA, it's very much the same for mental health, acknowledging that these are your conditions, these are the ways that you can better your life by taking your medicines, by staying active in the community. We know that in isolation, everything gets worse, not only depression and anxiety, but we know that psychosis gets worse as well. So doing the things that you need to do to better your life, to stay positive about your future and the things you want to accomplish. And also challenging kind of the preconceived notions that you have about medications. I think that a lot of times we use these labels, antidepressants, anxiolytic medications, antipsychotics, and that's really a simplification of what they do. Antipsychotics, for the most part, there are new medicines coming out, but antipsychotics are really dopamine modulating agents. They change the dopamine in your brain. And so there are people that take antipsychotics for depression. There are people that take antipsychotics for anxiety. There are people that take antipsychotics for mood stability and psychosis. So it's really not so much the label of the medicine, it's what it's doing for you. And the whole goal of the EAC and really a recovery-oriented mindset is to get people to move beyond the labels of medicines and come up with an understanding of what they do for you in your life.
Amie, I see you nodding along with what Dr. McCarthy's saying here, and it sounds like there's been a great evolution in just the approach to psychosis and schizophrenia. He mentioned the extended acute care units, new medicines. One of the ways I always, because this is a topic we kind of haven't gotten into in this podcast before, one of the things that I always love to talk about when we get to the end of these episodes is how does the future look bright here? What are some things that we're seeing that is maybe an evolution in the study of these things? The extended acute care unit, again, new medicines. Are there things that, and this question's open to both of you, Amie, I'll start with you in particular though, but just that you've seen in the study of psychosis and the study of schizophrenia, whether it's at St. Luke's or nationally, internationally, wherever it may be, that just feels like good steps in the right direction, that you feel like, okay, we're maybe starting to get a little bit of a bigger bite in this apple.
Yeah. Some really cool things that are out. And again, we always bring it up on this podcast, but social media, right? We bring up the pros and cons almost in every episode. But there are some actually very cool accounts on social media that are very good, and that will kind of give you a picture into what it is like to be living with schizophrenia. So if you don't understand, it's very hard to conceptualize what somebody living with this might be experiencing. But through social media or through AI or through technology, we can have simulations that can really help us, those that aren't affected by it, maybe put on special goggles or put on special headphones or walk through an AI-generated program that will really be able to mimic for us what that's like. Because I think being immersed in it is one of the things that helps us understand it. When we understand something, it's destigmatized. So I think we're doing a nice job of being able to have simulators out there. I also know that we've done a much better job in the therapy world of figuring out how to use traditional cognitive behavioral therapy with folks with psychotic disorders, helping folks really to use cognitive behavioral therapy to challenge their negative thoughts, challenge the hallucinations, both auditory and visual, challenge the beliefs, the delusions maybe that are untrue. And we're finding that by using some very specific CBT protocols with folks that are living with schizophrenia, we're able to make some really nice headroads, especially if they are on a medication regimen and are adhering to that med regimen. We're seeing a really nice a nice improvement for those people. Again, I think we're doing a better job as society providing supported employment for people living with severe and persistent mental illness, and helping folks to live more of a normal, quote unquote, normal life or functional life or life that's worth living for that person. So we're making some strides, I think, in that area.
So I would say, from my perspective, I think that although we are talking about the stigma, I think that the stigma has been slowly improving. And I think that as a whole, the field of psychiatry has done a much better job of involving the families and letting the families know about the warning signs, the way they can support their loved ones. So I think, just to Amy's point, I think we made some great crossroads in a more holistic approach to the lives of individuals affected with chronic conditions like schizophrenia. Also, there have been continued new medications that have come out. There's a new medication that targets what we call the presynaptic terminal of the neuron, because traditional antipsychotics have always targeted the postsynaptic terminal of the neuron. So there's now different areas that we're targeting with regards to the treatment of psychosis. For many years, we had postulated what was known as the dopamine theory, the dysregulation of dopamine contributing to the development of psychosis. There are new theories that also discuss the neurochemical known as glutamate and its involvement in psychosis. So our theory of psychosis has been revised over the years. We've had long-acting injectables that last for longer durations. There are ones that last 1 month, 2 months, 3 months, and now even 6 months of long-acting injectable support, which is really beneficial to people and allowing them to lead lives that are practically seamless, and you would never know that they even had this condition. And we're getting also injectables that only allow a single injection as opposed to multiple loading doses of injections. And then finally, it's a slow process to get insurance approval, but there are also patches that administer antipsychotic medications now. There's also very new, but medications that last a whole week with a delayed release. So we really have a wide variety of options to treat this condition. And I would also say, from my experience at St. Luke's, we've had good insurance coverage, and we've been able to get ECT approved for a wide number of individuals that are struggling with psychosis. And we have a great anesthesia team. So I would say not only have we continued to use ECT, but I think that we're showing the public that it's a safe, controlled procedure that has excellent results.
You know, Amie, as we kind of come back to the familiar things that maybe we talk about in this podcast, you mentioned immersing yourself in it. We talked about openly talking. We said, don't be dismissive. I think when it comes to something like this, certainly any sort of knowledge that we all can get to better understand what might be going on is good information to have. And I think we had a lot of that today. So to both of you, I think this was an excellent conversation. We'll have to come back because I feel like there's a lot more to this onion we can kind of unpeel a little bit down the road. So, Dr. Christopher McCarthy, it certainly would be great to have you back. Thank you for joining us for the Just Start the Conversation podcast today, my friend. We certainly do appreciate that.
Thank you. I'd be happy to join.
Excellent. And Amie, as always, I appreciate you, my friend. Where do we leave with here? Go Birds. It always feels like a good place for
yeah,
you
go Birds. And thanks again to Dr. McCarthy for joining us. After listening, you understand why I brought him.